We are live.
Good evening, everyone. I'm Dr. Aarti Heda. I'm the host for this session. I welcome you all to IOC 2024, the 4th International Ophthalmic Conclave Conference hosted by All India Ophthalmological Society. We are going to have a very interesting session, Ophthalmology Foundation session, wherein we are going to talk about evolving technologies for ophthalmic educators. I would like to invite Dr. Meenakshi ma'am to please moderate this session. Over to you, ma'am.
Thank you, Dr. Aarti, and a very happy good afternoon, good evening, good morning to some of you from all over the world. Thank you for joining in. I'm very thankful to the All India Ophthalmological Society and the Ophthalmology Foundation for putting together this fantastic session on evolving technologies for ophthalmic educators. And I will be introducing the faculty as we go along with the session. And to start off the session, I invite Professor Karl Golnick, who is a neuro-ophthalmologist and a professor in the Department of Neurology at Barrow Neurological Institute. Professor Golnick will be chairing today's session. He is also the chairperson of the Education Committee of the Ophthalmology Foundation, and he has an incredible amount of experience in not only neuro-ophthalmology, but in ophthalmic education in particular, with many publications to his credit. So I invite him to chair the session, to give his opening remarks, and followed by introducing Ophthalmology Foundation to the audience. And then he will be speaking on assessment principles. Over to you, Professor Golnick.
Well, good morning. From my standpoint, it's very early here in Arizona, United States, but welcome from the Ophthalmology Foundation. Our goal of this session is to emphasize the importance of continuing professional development of ophthalmic educators. The basic rationale is better teachers make better doctors, and then ultimately results in better patient care. It's crucial that educators stay up to date on the latest teaching methods to ensure our students become competent and, of course, great ophthalmologists. So we'll cover a few things. I'll talk a little bit about the Ophthalmology Foundation's initiatives, and then we'll talk about some assessment principles, assessing and teaching communication skills and professionalism, something called the Flip Classroom, and then how artificial intelligence can help you in your teaching endeavors. I'd like to thank Dr. Meena Swaminathan for her great organizational talents, and also thanks to the AIOS for their recognition of this very important topic. So I will now share my screen and get started. First, I just wanted to say a few words about the Ophthalmology Foundation and the Ophthalmology Foundation Education Consortium. This is a new international organization. This is not part of any other group. It's not part of the ICO, although many of the people involved in the OF are former ICO volunteers. Our mission is basically to support ophthalmic education internationally in order to improve global eye care and advance scientific ophthalmology by helping ophthalmologists become better teachers and providing training opportunities through sponsoring fellowships. This is our board of directors. You don't need to read all the names. We have, I think, a very international representation, including Professor Ravindran from Aravind is one of the board members, and you can see our executive committee on the top. Some of these people you may recognize, Dr. Bruce Spivey, Julia Haller, who's chairperson at Wills, Peter McDonald, chairperson at Wilmer, so on. So a great representation. We have two main initiatives right now, but we have two others in the works that I'll talk briefly about. The first is fellowships. So we work with the IOFF and provide about 100 fellowships per year. And these are aimed at low resource and underserved countries. Eligibility criteria include the candidates must hold nationality and be permanently based in a low resource or underserved country. In general, less than 40 years of age. I'm not sure who picked that number, wasn't me. have completed their residency training and obtained a degree. They have to have strong recommendations from their previous and their present chairperson, and committed to resume their position and apply the newly acquired skills and knowledge when they go back home. There's a lot more fellowship information available at this link and at this QR code. So please take a look if you are interested in this arm of our organization. The second initiative is to maximize the training ability of ophthalmic educators. Again, to enhance the skill of our graduates and our patient care. This QR code will take you to this section of our website. This is the main website, Ophthalmology Foundation, all one word.org. We have a number of initiatives. I don't have enough time to talk about all of them. This is something called the Online Teaching Skills Series. Again, this QR code will take you there. I think I have another slide with the same QR code. We started this in July of 2021, and topics include, these are a few of the topics. I won't read them all off, but you can see they're all aimed at improving teaching skills. We now have more than 20 modules. These are all free. And if you want, you can get 3 hours of US CME, continuing medical education credits, for each of these modules, again, for free. We have a number of other initiatives, something called Leaders in Education, where our online and face-to-face courses that are last 1 or 2 days. These are multi-year projects with groups either within a country or the whole country, depending on how big the country is. We have, of course, our website, which I just mentioned, a monthly newsletter, and then we do educator sessions at supranational and national congresses, like this session that we're doing right now. We have a mentorship program that can hook up mentors and mentees. If you want to be a mentee or a mentor, let us know. We have 2 new initiatives that are under construction. One is residency training program accreditation. So we're having an international system for this. We already have 3 programs in a pilot program. The rationale is there's extreme variability in training programs globally. And we think that accreditation is a way to improve and hopefully create a more level quality of those training programs. Skip that. The other, and this is very new, is an international examination. We are developing this at the moment. We have a committee working on this with some people you would know, actually probably several from India. The rationale is there's a need for a reasonably priced, up-to-date, high-quality international examination. So this will be coming. I can't tell you exactly when, but sometime, hopefully, possibly by the end of this year. And there's the pilot program that we've already completed in the College of Ophthalmology of Eastern, Central, and Southern Africa. We've already given an exam in this area. And there's contact information. That's my one of my emails, and then just contact for our organization. And now the second part of this is to talk a bit about assessment principles. And my objective is that you'll be able to explain why assessment is crucial, and then describe 5 principles of good assessment. So the number 1 reason is that teaching does not equal learning. So in order to know, and our goal here isn't teaching, it's that our students learn what we want them to learn. And so we can't assume just because we're teaching it, they're learning it. We need to measure their learning, and that's assessment. The other reason assessment's important is, I think we all know that students will learn what they know they're going to be assessed on. So assessment is the engine which drives student learning. So these are 2 important reasons to have good assessments. And what are good assessments? Well, there are some principles that we should follow. So number 1, we want to test the application of knowledge, not only the facts. So the facts are at the bottom of this pyramid down here at the know-how level. It's important to test that and assess that. But we also need to assess the whole pyramid. We really want to know, can our residents, when they graduate, can they do what we want them to do? Do they know it? Can they do it? So we need to have ways to show that as well. We also know the second principle that human performance is highly situation and case specific. That means that just because someone's really good or really smart, let's say, on a multiple choice question test, that doesn't mean they're a good surgeon. So pilots aren't licensed to fly any old plane. They're licensed to fly specific planes. And that's why we need more than one type of assessment. And that's the third principle, use multiple tools, multiple times. You want to pick the right assessment tool for the job. So you wouldn't assess professionalism, for instance, with a multiple choice question test. That doesn't make any sense. And we'll hear later in this symposium about a 360-degree, also known as multi-source feedback, as a way to do this. So assessment in healthcare, really and partly based on these first three principles, we have this pyramid. Someone once told me every education talk has to have at least one pyramid, but we need to assess the whole pyramid. So we need a way to look at the nose, the memorization. So MCQs, essays, orals, vivas. We need to look at, they show how to do something. So checklists, that's something very simple. And then hopefully we assess up at the top with rubrics. And this really has to do with these first three principles. Test the application, performance is situational, and we need to use multiple tools. The fourth principle is try to make, I put in parentheses, almost every assessment a learning experience. And that means you would like to give maximum feedback for each assessment. If possible, teach and assess simultaneously. And there are two types of assessments or feedback, formative and summative. Formative feedback is behavior modification. We want to reinforce good behavior, and we want to change behavior that's not as good as we want it, versus summative, which is, have they met the goal? Have they passed the course or been promoted? I think another word for formative assessments are teaching, right? That's what we're trying to do every day. And really the only difference between formative and summative assessments, the tools that we use, is how we use them. So if we have this timeline and we use MCQs and rubrics along this timeline, then they're formative. We're giving them assessments to improve them. But if we use the same MCQs and rubrics at the end, they're now summative assessments. And I think that's the main difference. And then the fifth principle is to provide high quality feedback. Give feedback that is situation specific, descriptive, and constructive. So high quality formative feedback should be frequent and timely. If you are involved with a trainee in cataract surgery, you are not going to tell them a week later, remember when you were doing that surgery last week and you need to do it a little differently. You want to give it as timely as possible so they remember it. If you're learning how to play an instrument, you don't play and your teacher then a week later says, oh yeah, here's what you should have done. You do it as quickly as you can. It should be expected and regular and based on firsthand data if possible. And it's designed to improve performance. That's what we're trying to do, right? Versus the summative feedback or the final assessment. So in summary of our assessment principles, we must assess to show that learning has occurred. And there are 5 basic principles. Assess application, not just facts. Performance is situation specific. Use multiple tools. Make assessments learning experience when possible. And give good feedback. So I thank you for your attention, and I will stop sharing my screen.
Thank you, Professor Golnick. I think we'll wait for questions to appear, and we will ask those questions in the intervals or gaps that we have between talks. And next up, we have a really relatively newer concept, I would say, for Indian residency programs, which is the 360-degree evaluation or the multi-source feedback, as Professor Golnick mentioned. And to give this very important talk, I invite Dr. Prashant Garg, who is the executive chair of the L.V. Prasad Eye Institute. He is an internationally renowned leader in corneal infections, antimicrobial resistance, and eye banking. He's a recipient of numerous prestigious awards, both national and international, and is on the boards of several international organizations, societies, and scientific journals. And he's a member of the Ophthalmology Foundation Education Committee. Over to you, Dr. Prashant Garg.
Thank you. Thanks very much, Meena. And I'd like to thank All India Ophthalmic Society for creating this wonderful education series and giving us the opportunity to share some of the education principles. I think Dr. Golnick has already alluded to what is the true meaning and the purpose of assessment. And let me take you to another dimension of assessment. Let me just share my slides. I hope my slides are visible.
Yes, sir, they are.
So the objective of my talk will be to discuss with you why is it important to perform 360-degree assessment. I'll also talk to you about what actually is 360-degree assessment and what are the competencies that we need to assess and how do we implement it in our programs. You just now heard that typical method of assessment comprises of multiple choice questions, but the question that we should ask is how successful these tools are in capturing traits needed for patient management. And you will agree with me that we often come across with a situation where a student who otherwise seems to be fully attentive, smart, and then when you talk to the nurse on duty, you get a feedback. He never comes on time when on call. Another common situation is where you see a student constantly raising hands in classes and answering all the questions. But if you talk to the other peers in the class, and they will provide a feedback that he is so rude, never allows us to speak. Smita was telling, he shouted on her. Let us look at the third scenario, somebody who scored very well in the multiple choice question. But when the attendee talked to the patient, the feedback came, the resident doctor did not explain me what will be done during my surgery. He was rude and he just told me, allow us to do our work. All these situations are not uncommon, where we find there is a paradox between the performance as evaluated during formative or summative assessment versus the true feedback coming from the people under the influence or those who are in direct contact with the resident or trainees. I'm sure you will all agree that the success of medical intervention does not depend entirely on the performance of a clinician. It's rather a team effort, and therefore, for the success of any medical intervention or medical procedures is dependent on how cohesively the team members are working with each other, how clearly the communications are among team members, and do the team members understand what the roles and responsibilities of each of these members are. So to summarize, the competency domains that determine the success of health professional depends upon mutual respect and shared values, clear understanding of roles and responsibility of other professions, making or being part of the team, communicate in a manner that support team approach, and teamwork, which is relationship building, values, and the principles. So in that background, we are now clear that if we have to evaluate our trainees, it is not just sufficient to evaluate them on the competency, skills, and the knowledge, but also to incorporate feedback from other members of the team. So what is 360-degree assessment? 360-degree assessment is defined as measurement tools completed by multiple people in an individual's sphere of influence. These tools assess competencies as well as behavior rather than knowledge or personality. What are the competencies that we need to assess as part of 360-degree assessment tool? Besides knowledge base and skill proficiency, you need to assess candidates on professionalism, ethical behavior, interpersonal skills, communication skills, and you may also would like to assess them on the use of information technology and facilitation of learning of other team members. Commonly, whenever we talk about 360-degree assessment, some of the competencies that must be assessed are professionalism, interpersonal skill, and communication skills. So after being aware of what 360-degree assessment is and what is the need of the assessment, the next question is, how do we implement it in our program? The first step for implementation of 360-degree assessment is be convinced with its value. Step 2, decide and get buying in from other members of your faculty. Step 3, develop or adopt already existing tools of 360-degree assessment. Some of the tools that I'll be talking about is how do we assess interpersonal and communication skill. And whenever we talk about this, the attributes that we are assessing are effective communication with patients and family members, effective and respectful communication with members of healthcare team, and use of effective listening skills. What are some questions that you can ask in order to assess on the interpersonal skills and communication skills are: resident communicates effectively while maintaining appropriate boundaries with the patients and families. Resident explain timely and effectively the progress and course of action to the team members. Resident elicit history using effective questioning and takes time and effort to explain the disease and interventions. In 2015, we published tools for 360-degree assessment. And on the interpersonal and communication skill, the tool asks following question. The communication is easily understood and the respondent can grade that on these 5 scales: agree, strongly agree, neutral, slightly disagree, and disagree. Similarly, you can ask more questions in order to get in-depth knowledge about this skill. And these are: listens without interrupting, is compassionate and respectful, establishes rapport easily with patients and families, establishes rapport with nurses, ancillary staff, and consultants, educates and counsels patients, is aware of and addresses cultural, language, and educational barriers to successful communication. Once you have adopted tools, the next is to educate all the stakeholders. And this is important if you want to implement 360-degree assessment. to ensure all the faculty members are educated about the need as well as how to conduct 360-degree assessment. The administrative staff, fellows and residents, medical students, nurses and ancillary staff, patients, and the students in the self-assessment skills as well. Another important requirement for a successful implementation of 360-degree assessment is team training. Typically, in a health setting, we see that the doctors and nurses are trained in two different colleges, and there is very little opportunity during training for them to work together. But for 360-degree assessment and developing ability to work together in team, it is important that there are few sessions that are held with the different members of the team together. So to conclude, the success in a healthcare setting does not entirely depend upon the knowledge of the subject, but rather effective patient management comprises of being able to solve complex problems, understand roles and responsibilities of other team members, collaborate effectively, and communicate effectively. I wish I was also assessed in a similar manner on a 360-degree basis. Thank you very much for your kind attention.
Thank you so much, Professor Garg. I'm going to pause here and ask a few questions that have come in, both to Dr. Golnick and to Dr. Garg. So first off, Dr. Karl Golnick. So you talked about assessments. I wish to know what is the plays or role of summative assessment in today's world? In the United States, have you completely done away with summative assessments? And what do you think of its role in other parts of the world? Does it still have a place?
Well, I certainly think summative assessments have a place. I did not mean to say that, that's all has to be formative. That's why I said almost all. I mean, I think we do want ultimately to know in that sort of situation where the student knows I need to pass this test to show everyone that I am ready to go out into the world. Now, in the US, we have an annual exam, but it's really not summative. In fact, it's the Ophthalmic Knowledge Assessment Program, or OCAP, and it's really not meant to be summative. It's meant to try sort of tell you where you are, to give you feedback as you go through your training. You don't have to pass that to move on to your next year. But we do use all of these evaluations that we've been talking about, the 360-degree. We haven't talked about others yet, but we have a number of different evaluations that are formative, but at the end of the trainees look at them as an aggregate, and they should be doing well enough to move on to the next year based on all of those formative assessments. Now we're looking at them in a different way. Okay, are these assessments showing us of be promoted to the next year of training? In the US, when you join a program, it's not a guarantee that you're in. Your contract is up every year. Most everybody pretty much makes it to the next year, but you have to look at these assessments to know. And of course, if they're borderline or along the way, our goal is to make sure that when we get to the end of the year, they're at the point where we can say confidently, yes, you move on to the next year. And then of course, they're at the end of the training, I think the board exams, I mean, I just mentioned as part of the Ophthalmology Foundation, we're going to be doing a summative multiple choice question examination for the basic knowledge kind of part of ophthalmology. So they certainly still have their place.
Right. Another question that is often asked is that, the OR is very busy and the clinic is very busy, and really I don't have time to do a formal assessment. I don't have time to do, a rubric-based formative assessment. It's one of the complaints that I often hear from, busy medical college hospitals or institutes. So how do you, what is your suggestion on how to overcome the time factor? for
Well,
assessment?
certainly that's the problem, I think, everywhere in the world. And people have busy clinics, they have busy operating theater schedules and so on. So there's a couple of things. The first thing is that when you have faculty show them a new assessment tool, oh my gosh, more work for me. It's so long. But I think hopefully the assessment tools that we're talking about, although they do look long, once you do them a few times, you realize this takes me a minute or two to fill out. It's not real, does not really take that much time. And I mentioned that one of the principles of assessment is timely. So you would like to do it in you observe it and you give them feedback. Now, an alternative would be if you're recording surgeries, you could look at the surgery later, but hopefully not much later in maybe that same day, look at the surgery and then fill out the rubric. That's one way. The other way that you can do it is have the student fill out the evaluation to see what they think, and then go from their evaluation and comment on where they are, how they're doing, and add in a little bit based on that. So those would be some ways, I think, to try to work it into the schedule. There's no question that assessments take some time, but I think you have to believe that the reason for assessment is to show that our students are competent and are going to be ready to go out there with patients. And there's got to be some kind of a balance with that.
Okay. All right. Thank you. And I have a question for Dr. Prashant Garg. And in your institute, a fairly large and very busy L.V. Prasad Eye Institute, how successful have you been in implementing the 360-degree evaluation? And when you started out, what were the challenges you faced?
So I think we started 360-degree assessment almost like 5 years earlier. And the first challenge that we faced is that many people are not convinced that these are skills on which a candidate need to be evaluated. So the faculty members said, no, how that is important, why we should do that additional time for me. The second was that I think it is not just the clinicians or the ophthalmology faculty that need to do. You need to get buy-in by the other members of the team. And we nowadays take feedback from nurses, we take feedback from the optometrist part of the team. Then we also take feedback from counselors and the front desk staff. And to really bring them on board takes some time. And many people do not understand the true value. If their immediate experience has been good, you will see that they all give very positive feedback. Whereas if in near past their experience has not been so good, and therefore we started putting those specific questions. So typically each member of the team is asked to fill about 6 questions under each attributes that we are evaluating. So it is a lot of effort, particularly bringing on board all the members of the team. But once they are on the board, it becomes part and parcel of and they collaborate and cooperate in that kind of an assessment very well.
Right. Also, I know in India, we do have a hierarchy sort of culture where, the doctor is on top and the others are below. So was there resentment from the trainees themselves, from, doctors when you started out, and how did you tackle that?
Yeah, no, there was no, because even earlier, I'm talking about when I was doing fellowship, and our chairman used to get, in an informal manner, I will call the nurses or the front desk staff as to how Prashant is as far as behavior how is his respect among patients. So I think while this was happening in a very informal manner, with the implementation of rubrics, it has become more formal.
Okay.
But we have so far not faced any problem as far as resentment from the residents and fellows is concerned.
Right. Wonderful. And before we move on to
Carl has that, I think.
Yeah, I was just going to ask Carl to comment, saying, I know Carl and Professor Prashant have published on 360-degree evaluation. And so I'd like you to comment, Carl.
Well, what the comment I was going to make was that, it's very important to get this information from the really 360. I mean, because my residents, my students are always very professional around me because I'm the boss, right? I mean, of course they're going to be professional around the faculty, the attendings, the consultants. But the question is, what are they like elsewhere? So it's, in my opinion, more important to get this information from the staff, the nurses, technicians, because they're the ones who are there on the ground with the residents. They're the ones who may observe this behavior. And, we've had residents where my faculty said, oh, they're so great. And then we get these 360-degree evaluations back and like, what? I can't believe this. I just can't believe it. So that was one comment. The other comment was, initially, when we did the 360 with the staff, everybody was great. All the students were great. They all got top grades. And I said, listen, I know this can't be true for everybody about everything. Oh, well, we don't want to say something bad about the doctor. We like the doctor, And I said, listen, our goal during the doctor's training is to make them better doctors. We need your help to do that. Because I'm not around. They're always going to be great with me. But we need to know if there's an issue to fix it. So we're not going to kick them out of the program probably because of what you said. We're going to give them feedback and say, here's what we understand. It's anonymous. Here's what we understand to improve them. So you are helping us improve these young doctors. And they said, oh, okay. And then I think they now are answering it as they should. And then the last thing is that we did publish a 360-degree assessment tool in the Canadian Journal of Ophthalmology in 2018. If you're interested, it's volume 53, page 145. If you want to look at that as a tool that you could use or modify as you see fit.
Thank you, Carl. Wonderful. Thank you, Dr. Prashant. We now move on to the next talk. We're very happy to have with us Professor Mohammad Moin, who is Professor of Ophthalmology at the Postgraduate Institute, Amiruddin Medical College, General Hospital, Lahore. He's a fellowship-trained vitreoretinal and oculoplasty surgeon with many awards to his credit, including delivering the prestigious Holmes Lecture in the last APAO in Kuala Lumpur, and I was in the audience. And his area of special interest is medical retina, particularly retinopathy of prematurity. He's also strived to achieve high standards in postgraduate ophthalmic education in Pakistan. He's a member of the Education Committee of the Ophthalmology Foundation, and he's going to be talking today on teaching professionalism. Thank you and welcome, Professor Moin. Technical team, please, would you play his presentation?
Thank you very much, Meena. Thank you for the introduction. Shall I play from mine? It was not going.
Just give us a minute. I think Dr. Ari is just sorting it out. Yeah.
Anyway, but before we start off, I think professionalism is something which is a very important thing which you need to learn during.
Hi, Mohammad Moin from Pakistan, and like to thank the organizers, especially Dr. Meena for inviting me to this talk on professionalism to the IOS conclave at the AIOS organized by AIOS. And today we are going to talk about professionalism And how would you teach professionalism? This is a very interesting topic, which I found was quite challenging. But more or less, let's get on with it. And the objectives of the talk are the participants should be able to define professionalism, explain the importance of professionalism in various fields, and discuss various methods to teach professionalism. So professionalism is not a job you do. It's how you actually do the job. And when you ask people, what is professional person, or how did you learn professionalism? People usually say that it's through the various role models in our life, which are teachers, maybe our patients, our mentors. They taught us about professionalism. It is not there in the lectures or in the books. The characteristics of professionalism, if you just outline a few of them, there are a lot of them, but the things which are most important is if you are professional, you should have good grasp of knowledge of and the job you're doing. You should be competent. You should know, and you should be confident in how you deal with that patient. The patient will exactly know in a few minutes that you're competent enough to do the job or not. Honesty and integrity, especially in challenging situations when you think there's a difficult decision to make and there is something in which ethical concerns are there. A professional will always maintain his integrity. He'll always stick to his words and be honest all the time. And he's always find a professional person, he'll always be accountable. He'll always justify what he says, and he has justification about how he talks about it. Then ability to control yourself is self-regulation, and there are different ways to do that. And a professional will always be able to self-regulate themselves. His appearance will be immaculate, he'll be well-dressed. That is part of a professionalism. People not dressed in jeans or probably not very adequately unshaven coming to work, probably they give an appearance of an unprofessional person. And a professional person will always communicate clearly, precisely what he wants to know and talk about. And time management, I think, is the most crucial part of a professional person. He will not be there talking here about. He'll be to the point and what needs to be done in the shortest period of time. Those are the characteristics of professionalism. So the question comes in, why do you want to teach professionalism? It benefits for the individual who you are teaching to. It benefits the organization, and it impacts on career advancement of people. And if you've got professionals in your organization, obviously you're going to work much better, much smoothly, with a lot of coherence. The learning of professionalism often takes in the hidden curriculum in schools and colleges because it's sometimes not there in the books. It's what's happening in the campus and how it's happening and how the institution plays its part in controlling how things are happening. That is how they're teaching professionalism. And it's seen and heard in informal planned sessions, such as in clinics or wards or in the corridors. How your teachers used to talk, how they would come at night to see their patients, to do their duty, not that they're getting paid for anything. Selflessness is the altruism that actually tells you that he's a professional. The teaching methods are incorporating professionalism into your education, the role of educators in modeling professionalism, and the use of case studies and real-life examples are the teaching methods which we are going to deal with. Let's see. The first one is a small group case discussion. We're going to have role modeling, as we discussed. Storytelling or narrative medicine is the most powerful tools of teaching anything, and that professionalism is one of them as well. A reflective practice, simulation, peer-assisted learning or PALS, guided discussions, and move on to small group discussions, discussion of ethical challenges. That suppose you had a person you were going to operate on and he ran into a complication. How are you going to explain that ethically to the patient's relatives after the operation, and how you're going to handle him? That a small group discussion can be held on that. And the point of discussion not being to arrive at the correct answer, but to examine all sides of the argument and to appreciate the complexity and difficulty to make a decision without an agreed official code of ethics. So that's, I think, one of very, very powerful tool. Role modeling, I think, when I started learning, teaching, preparing this lecture, I think this was the only method that you could teach professionalism, but there are 8 or 10 methods you can teach. But this is, I think, which I use quite a lot, is involved consciousness and unconscious activities. Faculty displays knowledge, attitudes, and skill. You have to control yourself when you're teaching or training somebody with you so that they learn from you, they learn good habits from you, and they inculcate them themselves. And the person who's role modeling demonstrates and articulates expert through processes and manifests highly professional characteristics of behavior, which we seen that when we were children, we would go and see movies and our hero was Batman, and we would copy them and we'll try to make him as a role model and do as he is. So it's very easy to sort of train people by doing role modeling. Storytelling or narrative medicine is very important in teaching, and teaches through case examples. It gives moral guides to a living good life, stories of witnesses that compel us to re-examine accepted medical practice, such as stories, those in doctor stories and letters to our young doctors. How can you forget stories which your teachers used to tell? That when we were in med school, our teacher, we just remember that a teacher would come and he would tell about the stories, how he used to be in London and how he was taught over there by one of his professors, and how elegantly he taught and what principles he taught them, and with adequacy. And that is something which you remember. Reflection, to look at yourself in action, thinking on your feet, and then reflection of action on action is after the fact, and reflection for action is used to improve future practice. I think that is one of the most important things with which you can correct yourself, which you can improve your reflective thinking. So if you are a professional and you think about yourself, that how you can ask your students to go and think about what they did wrong at the end, and that will tell them if they did anything professional or unprofessional and how they can improve themselves. It's a critical appraisal of one's experience, and it requires the ability to observe one's own surrounding and oneself. Simulation with the invent of new knowledge and simulators, and you're moving from traditional practice, apprenticeship model of seeing one, do one to teach one, because patients are humans and you don't want to just do one and teach one. You want to go through a simulation so that you get a graduated approach to achieving independence, the cognitive apprenticeship model. This is a form of experiential learning that allows trainees to practice a procedure or clinical scenario in a simulated environment before treating actual patients. You see, it's a very important part of getting to learn professionalism so that you are very professionally teaching your patients. Then we've got peer-assisted learning. People from a similar social groups who are not our professional teachers helping each other to learn. Senior residents teaching junior resident, I think that is a very good role model to teach the professionalism, and trainees sometimes find it's easier to learn from their peers rather than from their teachers, and it's much less intimidating learning from them rather than from the faculty. And peers are often more in touch with the educational needs of the trainee and their preferred ways of learning. And then in the end, we've got guided discussion in which the exposure to a variety of diverse perspectives is an opportunity to present content while drawing out lessons from different experiences. Faculty outlines in advance the procedure, and the participants are warned to wrap up some discussions to cover more areas and mentor, encourage, and guide reflection of the content. So those are the many methods through which you can teach professionalism. And you can incorporate professionalism into education. And we've already gone through this slide. And then whenever you teach something, you need to assess and evaluate. I think in the interest of time, we'll just leave that for the next session. The strategies for assessing professionalism, feedback, and recognizing and reporting professionalism. So these are the assessment tools which you can use, and I'll just briefly show you them. We'll not discuss them. With simulations for paper-based discussion, for paper patient surveys, self-administrated rating scales. So in conclusion, professionalism involves consistently achieving high standards, both visibly and behind the scenes. So you have to work very hard for being a professional, and in order to get to that area, you have to get to that level, and you have to be persistent and patient and show your best behavior and your qualities, which you have learned all of your career. Thank you very much again for the organizers, and looking forward to seeing you in the future.
Great talk, Professor Moin. Thank you so much for that.
Thank you.
Would you like to add any comments?
I think
Now-
professionalism, I think Carl has shown us there are certain vignettes he's used. I didn't put them directly in my slides. In the US, they showed some vignettes, some scenarios to the residents and the faculty, and then they compared the responses. And from that way, they gave feedback to the residents and the faculty, and that way there was one way of teaching professionalism, which I think was very effective, and Carl has published that thing in literature as well.
Again, how successful have you been in Pakistan to introduce and implement professionalism teaching and assessment for ophthalmic PGs?
For trainees, we typically, I would sort of traditionally, I started off with role modeling, but with different techniques. We do have patients, we come in and we try to tell them, look, what I would do is ask them to see a patient. And if they're making mistakes in the way their professional behavior, I'll just give them feedback at the end that, is this the way you would see yourself, or you would do this thing? Like simple thing, if you're putting eye drops in, sometimes it won't use a tissue to get that thing right. So I'll just use that. And then to encourage them, because with the newer generation, especially in this part of the world, people would prefer not to get their appearance the correct way. So some would be overdressed or some would be underdressed. So if you keep your sort of appearance in a sort of certain way, then probably they tend to follow, and they don't get to get away from it. Assessing as such, we get certain, when we take our exams, probably we will have one in when we do our exams for the fellowship exams at the College of Physicians and Surgeons. We have, when we check for, when we give, we have a station for counseling, then probably we'll check how the students are counseling the patient. So in that we have an assessment of how professionalism we have been, how good professionalism we have taught them. And then the way they would check their exam, we would give numbering to a certain part of all our exams, have sort of numbers for how professionally they check the thing. So they would get 1 point for doing that. So that is one way we get that thing done. And probably we see that when they go to exam, they're sort of rightly dressed and doing everything perfectly at that time.
Right. Also, Professor Moin, I know you've done a lot of your own training in the UK, I believe. And
Yes.
so do you think there are cultural differences when you talk about professionalism, or should you think it's pretty much the same throughout the world?
No. I've worked in UK, I've worked in the US, and I'm working in Pakistan. So the societies are totally different. You would think that the people are similar, but they're totally different. Because in UK, it's a very polished and a very sort of polite society, and everybody would be very polite and do things to you, and you learn very good and discreet manners. And that is what you come and teach to people in Pakistan. Because when you come over here and you see people doing certain things, you say, wow, what are they doing? And why are they being so crude in that way when you can do the other way around? I can give you an example. The first thing I ask them to do is check their head-eye movements. And the first thing they will do, put their hand like this, and they say, do this and turn around. I said, if you go to UK and do you do that, you'll get a long letter from them. Why are you touching me? And when you move to the US, then obviously they're more relaxed and they're more encouraging to teaching. And I was involved with Carl, and they'd be open to whatever you say, and there would be the inhibitions you would have in UK are pretty much less compared to the US. So it's a wonderful experience when you go around the world.
Yes, yes. And I think you're absolutely right. It's so important for us to learn these certain important professional standards and bring them and spread them and implement them in our own countries. I think that's how there'll be behavioral changes. And you've shown beautifully how professionalism training is as important as all other training in postgraduate ophthalmology. Wonderful. In the same vein, I have a question for Carl. I know that the milestones document is a daunting piece of work, but it's something that needs to be filled for every resident, is what I've heard. How much importance is given to professionalism assessment in the milestones document in the US?
So the milestones document came about some years ago. I was one of the authors of the first edition of that. And it has to do with the competencies that were mentioned by Dr. Prashant. And of course, the reason the competencies came up was because all of the emphasis in the US was on medical knowledge and surgical skills. And we realized that when we looked at quote unquote problem residents, usually it wasn't because they were stupid or had bad skills. It was because they couldn't talk to you or they weren't professional. And we said, well, why is that? Well, because we're not emphasizing it. Assessment drives learning, right? So we weren't emphasizing that. So these competencies came about, and now many countries, Pakistan, US, Canada, UK, have competencies that are supposed to emphasize to the students how important these things are. And professionalism and communication skills are 2 of the 6. And so the same for the milestones. The milestones are based on the competency. So every one of the 6 competencies has several milestones, which means you have to, during your training, progress along the milestones. And as I said, as we assess students during their first year, they have to meet milestones. And then at the end of the year, that's a summative kind of a thing. Have you met your milestones? If not, and there are for communication skills and for professionalism. You're muted, Nina.
Yes, I'm muted. No. Thank you so much, Carl. Today, so next off, we have Professor Eduardo Mayorga. We are switching the topics a bit to allow Dr. Pranesh to join us. Professor Mayorga is a consultant in medical education, eye department of the Austral Hospital in Buenos Aires, Argentina. And he is a member of the Medical Education Committee at the Pan American Association of Ophthalmology. He's also a member of the Education Committee of the Ophthalmology Foundation. He has worked extensively in the field of medical education for a very, very long time, particularly on areas of CPD guidelines, and is a pioneer of use of technology for teaching. Today is Republic Day in India, and for Republic Day is special because we salute our warriors. And we salute you, Professor Mayorga, because I know you're on holiday, on a skiing holiday, and you have woken up at some unearthly hour to join us to give a talk in this session, and we're eternally grateful. So thank you so much. And Professor Mayorga is going to be speaking on the role of AI in medical education.
You're muted, Eduardo, I think. We're not hearing
Ma'am, we
you.
are not able to hear him. It doesn't show that he's muted.
Dr. Eduardo, can you just select your mic as your headphones? I think you've got a Bluetooth this thing, so you need to select the mic as the headphones instead of the computer sound. Next to the mute button, there is a small arrow. Just click on it and the audio settings. And the mic, just change it to your Bluetooth headset.
Can you hear me now?
Yes, we
Crystal,
can.
Yes?
Yes,
Yes.
you're audible.
Okay. I'm going to share my screen now. Can you see my full screen?
Yes, your screen is visible. We are good to go.
Okay, thank you. Okay, so again, good morning to everybody. Thank you very much for this invitation. Thank you, Mina, for your generous introduction. I have no financial interest to disclose. I'll be talking today about artificial intelligence for teachers. My general goal is to try for all of you to use artificial intelligence to empower you as teachers. My objectives in this short presentation are that by the end of it, you should be able to identify, adopt, and adapt several applications that will make your work as teachers and educators easy. I will start with summarizing articles and creating mini reviews. For this, I use a software. It's called Quillbot. And besides the summarizing activity, it has other functions like plagiarism checker, grammar checker, and citation generator. It's very easy to use. All you have to do is when you go in, you either paste the text inside here or upload a document to the software. Once you've uploaded your document, it will appear here on the left, and the summary will appear at the right. At the top, you have a sliding bar that can make your summary short or long. In this case, for example, when it's short, from 2,500 words, you get 372 words as a summary. If you put it into long, then you get a summary of 1,000 words. Also, you can choose how the summary will show on the screen. In this case, we asked for a paragraph, so it's divided in different paragraphs, but also you can choose bullet points. And in this case, it will appear this way. This comes very handy when you want to use some of the text on the PowerPoint slides you may use to talk about the summary. Then you just download it and finish editing in Word. Also, you can use artificial intelligence to do mini reviews. This was done with ChatGPT, and it helps a lot with time, with just less probably than 3 hours work. I got 10 pages and 3,000 words of this review. Already it came segmented in different parts. I must say I've only tested this doing mini reviews, not general reviews or systematic reviews. But for mini reviews, it works very, very well. As I said before, it divides your segments the review in different segments. And it starts with the abstract, it gives you the keywords, and at the end of it, you get all these references. It looks like magic, but well, it's not that, even though you always may start with a short prompt as this one, like please write a mini review of the fifth classroom. In this case, I got a very mini review when I started, so I had to keep on asking for more words into it. And many times it's not just one prompt you have to put in, but several. So even ChatGPT can look like an Aladino lamp. Sometimes you need a screwdriver to get out all the information. One thing you must make sure you check before you publish your mini review is that you check the citations and the references. For example, sometimes some of the references that appear inside the text do not appear down here. So make sure that you review it and make sure everything is here and that these references here can exist. As you know, artificial intelligence sometimes can have hallucinations and invent things that are not real. Another use you can do with an artificial intelligence is detecting plagiarism, whether it's of your own work or from essays you may ask your students to do. For this, I also use Quillbot. You just scan the document, ask for the review. In this case, I scanned an article of mine that already had been published. Everything in red. Even when I also use the software to paraphrase this article, always there is track of the original article that appears here on the right side. So how can we try to avoid plagiarism when we do these kinds of reviews? Well, mainly cite all the sources you took your information from. Use quotation marks when you're going to use exactly the same text the author used. Paraphrase carefully, just not changing the words, but explaining the sense of the text you read in your own words. And of course, use a plagiarism checker to see the final result. Another use I give to artificial intelligence is for transcribing documents. Usually, I use it to develop performance support documents. As you know, when you attend a lecture or you attend a course, sometime after you start to forget all about that. So while doing the course, your knowledge grows. When you finish it, you're up here. Then as you go into practice again and time goes by, you start to forget. So performance support documents just will give you a hand many months later to review easily what you have learned before. The way I use it for this is to, for example, in the presentations, I give the participants the PDF with slides and the transcript here. And the way I use it is, first of all, we export the narrated PowerPoint to video using PowerPoint. That gives you a video. Then with Otter, you upload the video to Otter. I use this, but there is a lot of software that can do as a transcript. And if you look carefully, for example, into YouTube now, YouTube also can do that. Once I get that, you just look into the text, make corrections if needed. Usually it always writes wrong my name. And finally, we copy and paste the text on the side of the slides. And this goes out to the learners as a PDF. I also use it with to create mind maps. The mind maps, I use the text and ask ChatGPT to make open-ended questions of this. I put it into a mind map, and then I add the answers as branches of the question. So these mind maps serve as an auto-evaluation, because when the branches are closed, the learner can see if he knows the answers, and if not, he gets the answers from when opening the branches. And finally, creating images. Until recently, I usually got my images from just Googling them, because the software wasn't that good. But DALL-E 3 made a great change on this, and it's incorporated into GPT-4. In this case, you can see an example where I asked for a person that was auto-assessing himself. I gave him some more detail, and this is what I got. Here, the girl that had done a course and was forgetting about it, this is the image it gave with just this short description of what I wanted here. If you don't like this kind of drawing, you can ask her to do a more photographic image of what you see, and this on left is what you get. And even you can correct short details as this one, when I asked for this kind of image, but I wanted the loop to be more floating in there. I gave that instruction, and this is what we got. So finally, artificial intelligence will empower you as teachers, will help you save a lot of time. When you make reviews, always start with topics you know a lot about to be able to ponder the results. And there is a lot of software to use out there, much more than the one I spoke of. If you want now, just take a picture or make a screen capture of this. This will take you to my presentation with the notes on it. And if you need further help, you can just write to me to my email address you see at the bottom. Thank you very much.
Thank you, Professor Mayoga. That was quite a mind-blowing presentation. And I've heard that you speak before, and I'm as stunned as ever. And, you clearly are showing us so much about the role of AI. Thank you so much. I want to just pause here before we go to the next talk to ask the other speakers, the panelists, Professor Moin, Professor Garg, all of them, to weigh in, comment about what you think, how you think AI is going to change the way we educate. Professor Moin, would you like to go first, comment?
You're muted, Moin.
Please unmute yourself, Dr. Moin.
Sorry. Yes. So AI has got so easy making MCQs. Even assessment has become so easy. You can make MCQs, but obviously the important thing is once you get a scaffold of the MCQs, then you can work on and modify them, because usually the first difficult part in assessment is that thing. This is for clinical practice. Yes, AI is taking over, but with AI as Eduardo showed, that you can transcribe things, you can pick up things. I think the most important thing, if you go onto YouTube and you've got any copyright stuff, AI is quickly comes in, puts strikes on. So you have to be, it's playing double or triple role, that you have to be careful how you're doing it. It is continuously being monitored, and then there are ways you can use it to help you making presentations. Even making a presentation, you can just give ChatGPT a command and makes you 10 slides out of it. Obviously, you need to do your research and work on it, but I think it's very helpful on how it's going to change teaching, and I think learning for the students as well is very easy for them as well.
Thank you. Thank you, Professor Moin. How about Dr. Prashant? Like to hear your thoughts.
Yeah, so I have not used AI much, other than really drafting some of the documents. But I see that going forward, AI is going to be having a lot of scope as far as education is concerned. But also, we need to be careful as to how it is being used by the students and others. So I need to gain more experience in using AI for various activities.
Okay. Thank you. Professor Golnick, would you like to weigh in?
Well, I don't know. It seems like cheating to me, but I'm worried that I'm worried that somehow people won't learn as well. I mean, I don't know. I'm worried about things that are created by AI that people don't tell you is AI and so on. And that's a whole nother discussion, I think, about ethics and how to appropriately use AI. So I'm certainly not saying it's bad or anything. I'm just concerned that I don't know. It just seems too easy. So I know Eduardo he's got his hand up and would like to respond to that comment.
Yes, Eduardo, please.
No, I think Carl has made a very, very good point. And I think we should dedicate a full webinar on the ethics of using artificial intelligence. Because depending on how you use it and who uses it, it can be cheating. But on the other hand, for example, when you publish a paper, many times you work with people that help you, other authors, your secretary, your residents, and then the paper comes out. I think that the main thing is that anything you do and publish, if you used artificial intelligence, you have to say, I used this. But as I said, this gives for a full webinar on the ethics of using artificial intelligence. Thank you, Carl, for bringing this up.
Thank you. Thank you. And please, Dr. Santosh Honavar, here you have the ready topic for the next webinar series, AI and ethics of AI. So there you go. Before I introduce Dr. Pranesh, who has joined us from the UK properly, but he's the next gen, so to speak, educator. So I would like to hear his thoughts on AI, and then I will introduce you, Dr. Pranesh.
Thank you, ma'am. Thank you so much. AI is probably the most exciting, and AI in medicine, as we all know, is going leaps and beyonds above. And at MOOFIS, I'm experiencing the way AI is being used in medicine, especially in terms of imaging. In education, what I'm trying to do now is I'm trying to use or create mind maps, which is fascinating. The AI is trying to generate mind maps based on the topics. And I share the mind maps with my students as well. So that's how I'm trying to use with my students at present. So hopefully new things to come. Thank you.
Lovely. Thank you, everybody, for weighing in. And so now it's time to introduce our final speaker. And following his talk, if we have time, we will take one or two cases of problem residents for discussion. Pranesh Balasubramaniam is a clinical teaching fellow at Moorfields. He's a passionate educator. He was a medical officer and retina fellow at Arvind Eye Hospital, and he specializes in retina. He is a very popular online teacher and runs a YouTube channel called King's Crux, where he covers ophthalmology pearls. He has a huge number of subscribers and followers. You can call him an influencer in medical education, if you will. He's the youngest member of the Ophthalmology Foundation Education Committee. And today he's going to speak to us. He's come running from his work. Thank you for joining us. And he's going to be speaking about flipped classroom. Over to you.
Thank you so much, ma'am. And apologies for joining late. I'm still in the casualty at Moorfields, and it's very busy here. So hopefully I found a place for myself. And for the next 10 minutes or so, it's going to be about flipped classroom. So before I start, I want to thank Meenakshi ma'am for this opportunity. I want to thank Dr. Carl and my Ophthalmology Foundation Education Committee team. And I'm seeing familiar faces. I'm seeing my very good friend Aarti Heda. It's good to see her, and she's doing some brilliant work. I'm very proud of Aarti, and of course Santosh Honavar, sir, the legend. It's always a pleasure to be under sir's guidance and blessings. So let me share my screen. I hope this screen is visible.
Yes, Pranish, we can see your screen.
Brilliant. Right. So flipped classroom model is going to be the topic of discussion today. So what is flipped class? Before we talk about what the flipped class is and how do we flip a class, the objectives of the presentation, which is something which I learned from my Ophthalmology Foundation team, is the objectives for any presentation. So 3 straightforward objectives. First, let's define what is a flipped class. Number 2, let's describe the 3 levels of a flipped class. And number 3 is going to be, we're going to develop a very simple plan to conduct a flipped classroom immediately for our postgraduates or for our ophthalmic personnel. So flipped class, as the name implies, it's going to be the reverse of a traditional class. So in a traditional class, what happens is that we have a lecture, we have a doctor, a teacher who's coming on and take the class for the students. And what then happens is that the students go back home and they do their homework. I think, or presumably they do their homework. That's the traditional classroom which we have all been taught over the years, right from our school days. What is flipped class? It's just the opposite of it, where we give the resources, we share the materials to the students beforehand. So students read, prepare for the lecture, and they come to the class. So in the class, what we are doing, we're just making them to apply their knowledge in the classroom in the form of activities, or what we call as classwork. So homework and classwork, it's very nostalgic for us, right? I remember our school days are filled with homeworks and classworks. Speaking of nostalgia, you might remember this particular chocolate from Cadbury's called as Ulta Puck. I wonder why Cadbury's buried this chocolate. This is an interesting chocolate where you have the wafer outside and filled with chocolate inside. So flipped class is essentially an ulta class. Ulta means reverse or opposite. We're just going to turn the tables, reverse the roles. So what's happening before the class? The students are learning, and during the class, they're applying what they have learned. And after the class, they're creating something new out of their learned and applied experiences. So there are essentially 3 levels happening. That's level 1. What is happening before the class is that their brains are getting primed with the content. In level 2, in the class, they participate. And level 3, after the class, they produce. So prime, participate, and production of content, of knowledge. So let's go level by level, one by one. So first level is going to be what's going to happen before the class. Probably the easiest from the teacher's perspective is sharing the resources. We know that we just tell them what to read, what not to read. But even though it's the easiest from the teacher's perspective, it's the most important level, in my opinion, because it's important for us to share the relevant resources, relevant materials, which are pertaining to the topic of discussion. This is one example. The best resource to offer is a video which you can create. So fortunately, I have these videos for my students on YouTube channel. So I try to pick those topics which I have already had a video back. So I share the videos before the class. So the students get adequate time to learn, to read about, and they watch the lecture. So they get a bit of a brief knowledge of what the class is all about. I used to share these 48-minute videos, but I realized that nobody watches that. So I was very disappointed. Then I tried to make these short videos. This is not very short, but this is a simple video which talks about ocular embryology in just 8 minutes. So now I've made a commitment that I'm teaching you, I'm giving you a resource which is just 8 minutes long. So you can easily find your 8 minutes in your busy schedule. So they watch these 8 minutes, and when they come to the class, they're much more prepared, or they're much more primed. Okay? So this is one of the videos which I made for my students. Okay, now what we know is that there are 3 important components or 3 layers as far as embryology is concerned, which anybody knows. There is an ectoderm, there is endoderm, there is a middle mesoderm. So you might get the picture, what it is about. So I've started with the general embryology, and I'm progressing through the end of the ocular embryology. This is just a synopsis of a discussion, what's going to happen in the class, right? You don't have to do what I'm doing. I'm trying to draw it on a smart board. I'm trying to record it. I'm doing a lot of extra work. But the easiest is you can open up your PowerPoint presentation, what you have prepared, right? And open up the presentation, and you can screen record it as you are narrating the presentation. Or simply put, you can open up your Zoom and you can share the screen, open up the PowerPoint, use an external mic like what I'm using, a headphones, and record it. When you're going to record the screen or record the Zoom with your audio and with your slideshow, now we have got a very interesting, very useful flipped class material. And we can share that flipped class video to the students beforehand, maybe a week or so. So what happens now? The students have adequate time to prepare and read for the class. So they have a good material. They have a video which is based on the lecture, what you're going to take for the students. And they come to the class very well prepared. Even if you don't have the time to prepare for such a video, because I know most of us prepare our PowerPoint slides the night before our presentation. I'm guilty of that also. So what we can do is, if we can prepare the PowerPoint at least some time back, a couple of days back, and if we can convert the PowerPoint into a PDF, and if you can share that PDF to our students, I think that's going to be a brilliant idea again. You don't have to be a video. Video is the best way of giving us a flipped resource, but a PDF of your PowerPoints.
Sorry to interrupt. Just make a PowerPoint full screen. It's still we are able to see the toolbar or no.
Now?
If you can reshare again, I think that would be a better option.
Sure.
I think that's the slide he has on his presentation, Sunil, that he's just showing an example of how he's doing it.
My bad.
Okay.
Yeah.
Right.
Sorry,
Is it okay?
Pranesh, you're breaking the flow. We can get back to that.
No worries. I thought there was something wrong in the way I was doing. Yeah. That's supposed to be an example, actually. It's not the thing. Okay. I think you thought it was my PowerPoint slide. Okay. No worries. Thanks for that. I know it's understandable, right? So you just share the PowerPoint as a PDF and share with your students. I think that's going to be much easier for the students to go back and read. This is an interesting example. We had one of the classes, a flip class on amblyopia. So we shared all the DOS articles. I think most of us are familiar with this DOS, or Daily Ophthalmic Society articles, which are very famous amongst postgraduates, which we can get it online. And still, many students are going to religiously transfer that DOS article bank to the next generation of residents. And you can see here in this, we shared a list of or a number of documents for the students, and look at the variety of the documents we shared. There's one document which is a study. There's one document which just had the Q&A, and there's one document which has just the algorithm or a mind map of the amblyopia. So a variety of topics, variety of materials sharing with the students before the class. Now, what happens is that students now are very happy that they have received a good set of materials, which they use it for the future reference as well. And also, there are different learners. Some of them don't want to spend time reading or watching a 40 minutes video. Some of them like to watch videos. Some of them like to read articles. Some of them like to just read a one-page article. So we all come in different shapes and sizes. Teachers have to understand that students have different styles of learning something. And it's important for us to understand and appreciate and be empathetic of that fact. So that's to do with the level 1, where we share the materials beforehand. In level 2, we are allowing the students to participate in the class. That's the most challenging, because that's very tricky. What most of us end up doing is we take the class again. We are going to show the PowerPoint slide and we're going to take the class, right? It's going to be again back to square one. It's okay. I'm not saying it's wrong. To begin with, let's flip one by one. First time, when you're starting with this flip class model, I would recommend to share the resources. And during the class, for your comfort, you can just take your normal PowerPoint presentation. And in upcoming class, try to make it more interactive. And how we can do that? Multiple ways. Please go crazy with this. Creativity, sky is the limit when it comes to make the students participate in the class. So what we have tried to do is, just a basic overview is that the whole point of this flip class is, the students are now becoming the teachers. The students are going to be the speakers. And the teacher, the tutor, is going to be a facilitator or just a moderator. So an example would be to split the students into multiple teams, give them each one of them a problem, a case, and let them discuss and let them come up with a solution or an answer for each problem and let them present to the class. Now, what's happening here? The students are brainstorming. They're trying to apply the theory, what they have learned, into a real case-based or a problem-based scenario.
And when each one of them or the chosen ones are going to present something, now they're going to communicate well to the audience, and communication is very important. One of the biggest reasons why students, especially from India, they struggle a bit more in the Viva examination because they don't really have the practice of talking or communicating, and flipped classroom facilitates that. This is one example where we brought out some problem-based learning, some case-based scenarios, and we had these debates. So we split the groups into two groups. One group talked for a particular treatment in amblyopia. The other talked about against that. So we had different treatment options. So if the topic facilitates a debate, please use that. Now, this is one of the classes where on thyroid eye disease, we shared an MCQ before the start of this class. We asked the students to answer these MCQs. Of course, we didn't give these answers. We discussed these MCQs one by one. Now, this is a very interesting, it's like a quiz. Also, it's kind of like putting a study there. You are giving a pre and a post-lecture MCQ. So it's a great idea for research into medical education. At Moorfields, what we do is we share these materials to our medical students, and medical students go through these materials before coming to the class. And by the end of this week, I'm going to use the same template to discuss, to review, and reflect what they have learned through problem-based. So what we can do is just a couple of books. These two books are very famous amongst those who are prepared and those who have excelled in their fellowship exams. It's FIC or FRC of that. Aarti Heda would be knowing about these books as well. We can use these books as templates. We can get these MCQs and we can give these MCQs before the start of the class. Now, students will understand that, okay, these MCQs are from a book which they will read in the future or they would have read in the back of, in the past. But anyways, these books are going to be very high yielding books for them. So we're giving something, we are using resources which are very relevant. This is a fantastic book. This is a fantastic book to get case-based reviews called Case Reviews in Ophthalmology. So we got plethora of resources, plethora of ways where we can make use of participation in the class. What's happening after the class? Now, this is going to be more philosophical or more broader view of it. Simply put, what I do is after a class, I ask the students to take a question from their question bank of their DNB or MS question bank and make a set of notes. Use their textbooks and write it. Now, what's happening here is now they have their own set of notes. This is called as owning your learning. When the students are going to create their own learning material from the knowledge what they have gained and from their application in the class, and now they are creating their own material, which really gives and consolidates their knowledge. And not just that, this is also going to facilitate more thought process, which are being provoked. One thing which I could have done, looking back in the backside, is that during the amblyopia class, I could have asked my students to go to the iPad and open up the various and look for various amblyopia applications which are on the App Store and look at each app. Now, what I'm doing, I'm utilizing the power of the next generation. I'm trying to tap in the technology inside the youngsters. That's how we teachers have to make use of them, not the other way around. Optimize them. Maybe you can even try to bring an application in amblyopia from your institute. So when we tap them and we use them in the right way, we get the best, not just for them, also for our institute and for our patients as well. So essentially, what we are doing is, again, coming back to this. Before the class, they're learning. During the class, they're applying. And after the class, they are creating something novel. It can be some research question. That can be an innovation. No matter what it is important for us to follow up and make sure the students are making the most out of the flipped class. So what are the advantages? 3 things. Number 1, we are making them better communicators because they are participating in the class. They're opening up their mouths and they're talking. That's the skill. That's a skill to develop. Even for the patients, even for the teachers, anywhere in the world, communication is the most important skill, the most precious soft skill ever. And it makes them engaging. It kind of removes the boring lectures and it creates much more fun, interactive, a gamification or a game-like way of learning something. And it makes them accountable. When a teacher is doing so much effort in creating these resources and making all these plans, they respect that. They do reciprocate it also. So my suggestion, my advice to the early teachers who are taking up this flipped classroom is flip one level at a time. So first, let's share the resources and then take the normal class. In upcoming classes, try to introduce the elements one by one. So that makes it much more easier for the students and for you as well. So I'm going to end here, and thank you so much for your patient listening. I hope I've given or shared some interesting insights into flipped class. I would welcome more thoughts from the expert panel group as well. Thanks again. Take care.
Fabulous, fabulous lecture, Pranesh. I really want to be a student all over again. Maybe your student. I know I started off at the era before PowerPoint. So these are very exciting times for both students and for educators. I have a quick question for you before I have a couple of more questions for Eduardo. And and then it'll be time to wrap up the session. Now, in the Aravind system, for example, or in the Moorfield system, I know there's a lot of hard work to implement a flipped classroom. There is a lot of work for the educator as well. So how successful is this? How easily do people buy in?
Great question, ma'am. Actually, the biggest problem with flipped class is that the students have to prepare for the flipped class. When they don't do that, it's all going for waste. There is no point of flipped class, actually. It's going to be all over again. That's going to be where we have to be very sure that we are giving the materials in the right way, the right amount, not overwhelm them, but just give them the right amount, give them in multiple varieties, big, small, shortest. So it's like YouTube videos, like give a big one, a micro learning modules, a nano learning, like shorts, just under a minute. That's what I do at Moorfields. I'm trying to give one resource. For example, I'm going to take an acute angle closure glaucoma, an important topic for undergraduates as well as postgraduates. I'm doing that into a 40-minute videos. I'm doing that into an 8-minute videos. I'm doing that in a 1-minute video. I'm sharing all these three along with the PDF of my notes to them beforehand. Now I've given them all. Now the ball is in their court. And at very first, it might be difficult, but when the students understand that they are being given the best material, they are being given the best teaching experience, then they realize that and they reciprocate it. At some point, it will happen.
Thank you. I know Eduardo has done a lot of work in the area of flipped classroom. Would you like to add a comment, Eduardo?
Yes, thank you. Well, first, congratulations. Pranesh, it was a very good presentation on flipped classroom. I want to comment on two things. Pranesh mentioned some students are prepared. He also said that he first starts with going through multiple choice questions. What I suggest is that this is not done with just that residents stands up and answer them. I recommend using an answering system where you collect what each resident answers, and they cannot see what the others have done. This will give you an idea on how much the residents have studied or prepared for this. Make them just knowledge questions, because the application will come during the exercise. So just make knowledge questions, because if they do not have the knowledge, they will not be able to apply it to discuss the cases. And the other thing regarding work for teachers, but since I started testing this, it made my work much easier, because I just had to have the cases for application. I didn't have to prepare the lectures. And in the web, there are many lectures that are much better than the ones I can. And the last thing I want to comment is that it's good initially when you start, especially with first year residents, you give them, look at this, look at that. But then you must prepare them for what will be their continual medical education after they leave their residence. Because then they will not be confronted with cases, they will be confronted with patients. And many times they will not have the answer. And they must be prepared to go and look for that information. So another way to add to this is give your residents the clear objectives of what they will have to solve during their active, and give them nothing. Get your best. So they have to go and look for the information and be able to solve the cases with. It's also important afterwards to discuss where everybody went to, what did they look at, and then discuss this kind of searching for knowledge when you are confronted with a real case in real life.
Thank you, Eduardo. I think we're almost at the end of the session. I want to take a few seconds of quick promotion. This is for all the educators out there and for all the senior residents or fellows who are considering to go into medical education. We have an exciting pre-conference day for you, for the educators, on the 13th of March, before the All India Conference in Kolkata. I really invite all of you, and many of those who present today are going to be present there as well. We also have very experienced international faculty, Dr. Matenge, who is the president of the African Ophthalmology Council, and Dr. Professor Helena Felipe from Portugal joining us. It's going to be a wonderful day of discussions and new areas to explore for medical educators. With that, I hand over the session for closing remarks to Professor Karl Golnick.
Well, thank you. Thanks, Meena, and thanks all the speakers. I'm just going to share my screen briefly to show that all of these topics that were discussed today and a lot more are available for free online. This is the QR code. You can take a screenshot. I know this is being recorded, so you can look at it later, but all the topics in more detail and from international speakers. And again, you can get, it's all free CME, but I think we had some exciting topics come up. And as Meena said, it makes you kind of want to go back and be a student again, although I'm not going to do that. But thanks everybody for attending. Again, thanks to the AIOS for recognizing the importance of this topic and for collaboration with the Ophthalmology Foundation. And in the interest of time, I will stop there.
So I would like to thank each one of you for making this session very, very informative and very interesting. And I'm sure a lot of people like me will definitely get benefit from this. Pranesh, as usual, you were the best. So being the junior most in the panel, I thought I'll give the word of appreciation. So I'll request each one of you to please switch on your videos and give your best smile so that I capture this moment with you all. So here we go. Thank you so much. So just a quick reminder, we have our next session coming up in Hall B, which is on artificial intelligence in ophthalmology. So you all can join us in Hall B. Thank you so much. Enjoy your evening and rest of the day.
Thank you.